This breakfast was sponsored with a generous contribution by the St. Joseph Health Community Development Fund, Executive Director Gabriela Robles, so we want to thank her. California Convergence helped pay for these facilities, for the use of these facilities, and California American Planning Association is responsible for the outreach, and I related professional credits for planners in attendance today. And then institutional sponsors who contributed to the event were Professor Michael Montoya from the Department of Anthropology and Chicano Latino Studies, Professor Vicky Ruiz with the Department of History and Chicano Latino Studies here at UC Irvine, the UCI Department of Planning, Policy, and Design. Many of our students in that program are volunteering today here or in attendance. And finally, the program in medical education for the Latino community, which is a specialized program in the School of Medicine that trains doctors to work specifically in Latino communities in California and throughout the country. It started out as a program, was championed by Dr. El Manetta, was championed by our Chancellor, Michael Drake, who we're grateful for his leadership on this program. And because of its focus and because of its goals, the UC system actually has embraced it, and it now is represented in various forms at all of the medical schools in the UC system. So I'm very proud of that program. Without any further ado, I'd like to introduce Amy Buck from the Orange County Healthcare Agency, who will introduce our guest speaker. And again, thank you all for being here, and I look forward to meeting you as the day goes on. Thank you.
Good morning. So I'm Amy Buck. I work at the Orange County Healthcare Agency, which is the local health department. And I have the great pleasure this morning of introducing Dr. Linda Rudolph. As the first speaker for today, let me just orient you to your packet. And so all of the speaker biographies are in the packet. And so I'm not a big fan of reading to people stuff that you already have in front of you, because I think you can do that. So I'm going to read some of Dr. Rudolph's bio, but then also tell you why I think she's going to be a super cool speaker. So anyway, so you've got your speaker biographies there. So just to read you a little bit, Linda Rudolph is the co-director of the Climate Change and Public Health Project at PHI's, the Public Health Institute's Center for Climate Change and Public Health. She is also the principal investigator on a PHI project to advance the integration of health in all policies in local jurisdictions. Previously, Dr. Rudolph served as the deputy director of the California Department of Public Health Center for Chronic Disease Prevention and Public Health, and the health officer for the public health director for the city of Berkeley. And there, Dr. Rudolph chaired the Strategic Growth Council Health and All Policies Task Force and the California Climate Action Team Public Health Work Group. The rest you can read. Let me tell you why I'm so pleased to be able to introduce Dr. Rudolph and why I asked you to be here this morning. So when I started working on planning this conference with Victor and Susan and all the people that you just heard about, we kept talking about how can we bring together health professionals and also planners. And historically, as you I'm sure know, health professionals and planners used to talk to each other quite a bit in order to create a infectious disease safe environment. But then things kind of went differently, and our disciplines kind of separated, and I want to reunite that marriage. So, and then when I thought, well, who best can speak to all the different mindsets and perspectives that are going to be in the room, I immediately thought of Linda, because there's no greater champion in my mind than Linda Rudolph when it comes to talking about how we can create healthy, vibrant communities where there is health in all policies, but there's also tribute made to what each of those disciplines bring. Linda has really been the leader in the state and also has been nationally recognized for being able to bring together disciplines who care passionately about the work that they do and come together and bring a common vision and a common voice. So it is my great honor to welcome this morning Dr. Linda Rudolph.
Good morning. Thank you for inviting me. I'm really excited that this conference is happening and that there is a room full of people that do care about building this relationship between planning and health. I'm certainly not a planner, and so I'm not going to actually talk too much about planning and health. Others who are planners and have more expertise in that than I will talk about that in a while. I'm going to talk a little bit about the context and the sort of the journey that I went on and that people in the state health department went on trying to figure out how to address today's health challenges. And I think we all know that, as Ralph Waldo Emerson said a long time ago, health is the first wealth. We all cherish our health and the health of our families. We cherish our health because it allows us to do the things that we want to do. It helps us to be productive. We also cherish it because it really has a big impact on our economy and on our productivity and on our ability to take care of our children and our parents. Unfortunately, despite the fact that we're one of the wealthiest nations in the world, people in the US have shorter lives and poorer health than almost any other developed industrialized nation. We rank 14th in industrial countries in life expectancy at birth in 1980, and by 2003 we'd slipped down to 23rd place. And that's despite the fact that the US spends way more money on health care than any other industrialized nation. So we're up to almost 18% of our national GDP spent on health care. But we're not, if you look at the data on our shorter lives and worse health outcomes, doesn't appear that we're getting our money's worth. So, you know, what's driving our lower life expectancies is really chronic disease and injury. About more than 2/3 of deaths and disability in the US and California is related to chronic disease and injury. And if you look at what's causing the chronic disease, you'll see it's really three things: tobacco consumption, and even though we've made huge progress in addressing tobacco consumption, we still have about 3 million people, more than 3 million people in California who smoke. Poor diet and physical inactivity. And alcohol consumption is also a really important contributor. So many studies have demonstrated that the best way to address chronic disease and improve health outcomes isn't actually through medical care. Healthcare accounts for about 10 to 15% of our overall well-being and health and life expectancy. Our inborn genetic predispositions accounts for some. Our behaviors, smoking, drinking, not exercising, and so on, contribute a lot, and our environmental exposures contribute a lot. But what's driving our health behaviors and our health outcomes? This is a little story from Health Canada, and it basically asks, why is Jason in the hospital? Jason's a 5-year-old boy. Well, Jason's in the hospital because he has an infection on his leg. But why did he have the infection? Well, he has the infection because he was playing in a junkyard next to his house and he cut his leg on some steel. But why was he playing in a junkyard? Well, he was playing in the junkyard because there isn't any park in his neighborhood, and lots of the kids play there. It's never supervised. Well, why does he live in a neighborhood where there isn't any park? Well, his mom is disabled, his dad is unemployed, and they're poor and they can't afford to live in a different neighborhood. But why? So what I really want to explore a little bit is the but why. Because if we don't talk about the but whys, we're not going to address our health outcomes, and we're not going to address what we call the social determinants of health. The whys are what we call the social determinants of health. And we know that these social determinants of health are really what drive our health outcomes and also what drive our health behaviors. So there's a long list of the social determinants of health. I'm not going to go through all of them, but I'm going to just touch a little bit on some of the most important ones. Education. We know that education is associated with life expectancy, not just in the individual, but a mom's education determines a child's health and determines infant mortality rates. Adults with lower education consistently report poorer health and have higher rates of obesity, diabetes, heart disease, almost any of the big contributors to shortened life expectancy. Race and ethnicity. Again, consistently, we see that Latinos and African Americans and Vietnamese have different life expectancies and different health outcomes. Income. Consistently, the better off you are economically, the better your health will be. And that's true across race and ethnicity. So regardless of whether you're white or African American or Asian or Latino, the wealthier you are, the better your health will be. We also know that inequality in and of itself drives health outcomes. And this comes from a book called The Spirit Level, written by two British researchers, where they compared developed nations and United States, looking at a whole range of health outcomes: life expectancy, homicides, teenage births, obesity, mental illness. And they compared the outcomes depending on the level of inequality measured by the difference between the top quintile of income and the bottom quintile of income. And consistently, both looking between nations and between states, found remarkable correlation between the level of inequality and all of these different health outcomes. So in addition to these sort of core social determinants of health, like income, education, race, and ethnicity, we also know that our social, economic, physical, and services environments drive our health outcomes. Whether we have safe places to walk and to exercise, how much time we have to spend on a crowded freeway to get to work, what kinds of access we have to healthy foods, or how easy it is for us to get unhealthy foods, or how many liquor stores there are in a neighborhood, what our social environment is, whether or not we have access to good early childhood education, what the peer relationships are like, whether or not we're subject to domestic violence or bullying, what we see on the television and the radio in terms of attitudes toward women, toward different races, or toward violence. These are all impacting our health and the health of our children. And what our economic status is, whether we have enough income to not have to worry about whether we're going to put food on the table. The Institute of Medicine said it is unreasonable to expect that people will change their behavior easily when so many forces in the social, cultural, and physical environment conspire against such change. What we also know now is that a lot of these social determinants track together. That's no surprise. You all know that. Some neighborhoods have lots of poor people, lots of people that haven't finished high school, no playgrounds, lots of air pollution, lots of liquor stores, lots of fast food. I suspect the majority of people in this room don't live in those neighborhoods. There's other neighborhoods that have farmers markets and beautiful playgrounds and nice bicycle paths. These differences in neighborhoods and living conditions result in health inequalities. which are the preventable differences in health outcomes that are the result of the systematic and unjust distribution of the social determinants of health or the conditions that support health. And we see these health inequities driven by differences in living conditions all over the country. This is from Alameda County, work of the Alameda County Health Department, where the green neighborhoods are the neighborhoods with parks and nice amenities, and the red neighborhoods are the areas with lots of toxic exposures and low literacy rates, high levels of unemployment, high levels of poverty, low levels of home ownership. And you can see that these differences in living conditions lead to very, very significant differences in life expectancy. Across America, you see the same thing. Some neighborhoods in America have life expectancies of 81 years. Others have life expectancies of 65 years. That's a big difference. You see it in Washington, D.C., where you can measure life expectancy by metro stops. You can see it in Berkeley, where I was the health officer. And it's not just life expectancies. It's rates of hypertensive heart disease. It's rates of diabetes. And you can see it in Orange County. And this just shows death rates by zip code for people age 18 to 44 and for people age 45 to 64. Not unexpectedly, you see these differences in the social determinants of health, and that's what's driving the differences you see by zip code in Orange County and everywhere else. So we know that Latinos in Orange County have a substantially lower educational attainment than whites. We know that the annual income of households in Orange County differs substantially by race and ethnicity. We know that the poverty rate differs substantially in different communities within Orange County. We know that the prevalence of obesity in children differs by race and ethnicity, and these are in very young children, where this isn't because the kids have decided that they're gonna go out and eat a lot of, drink a lot of sugar-sweetened beverages. And there's a recent study actually that many of you probably heard on the radio talking about how important early childhood obesity and overweight is in determining adult obesity, and how hard it is for people who are overweight in the early years, 0 to 5, to actually overcome that. And it's partly related to whether or not children are exclusively breastfed in the first 6 months of life, which we know reduces the risk of diabetes and also of other chronic illness in adulthood. And we see that breastfeeding rates are significantly lower among Latina and African American women in California. And that partly reflects differences in the practices of hospitals. We know that in Orange County, there's higher rates of feeling sad or hopeless or having considered suicide among Latino children compared to white children. And we also know that there's differences among different groups in Orange County that really change their access to healthy health care and healthy food and healthy amenities. So older adults, large proportion of Vietnamese elderly in Orange County don't drive a car, which means they're reliant on having transit and assistance in getting to the amenities that they need to remain healthy. We know there's a large proportion of children in Orange County who need food stamps to get an adequate diet. And we know that in Orange County, there's some neighborhoods that have significantly greater exposure to toxic substances than others. This is a map that shows part of Orange County from CalEnviroScreen, which is developed by the Office of Environmental Health Hazard Assessment in the state. Cali, PA, and the orange zip codes are zip codes that are in the top 10% of zip codes statewide in terms of a combination of their socioeconomic status and their exposure to air pollution, freeways, hazardous waste sites, and so on. So in the Bay Area, as we looked at maps like this, and you'll see more maps later today, there's maps outside, but as we looked at maps like this and started thinking about what are we doing in public health to address these issues, we developed this framework, and it's a framework for addressing health inequities. On the far right, you'll see mortality, disease and injury, and risk behaviors. And for a long time, that's really where we focused our attention in public health. If we think about what I just showed you, though, that's not going to get us very far. So we started thinking about what's the role of public health in addressing these physical, social, economic, and service environments that actually drive health outcomes. And we recognize that those environments don't just happen. They're not just an act of God that some people live in really bad neighborhoods and other people live in really great neighborhoods, or that some people have access to healthy food and other people don't. Those environments are really shaped by decisions that people make in all sorts of institutions. Businesses make decisions about what they're going to sell and what they're going to advertise. Government agencies make decisions about what kinds of transportation system they're going to subsidize or what kind of agricultural products we're going to subsidize. Schools make decisions about what's going to be in their school lunches. All these other institutions make decisions that have very profound impacts on our community's health. I don't make those decisions except insofar as I'm a citizen and I might be engaged in voting or in advocating or whatever. But as a public health professional, I don't decide where our transportation dollars go. I don't decide whether USDA is going to subsidize growing corn in the Midwest or growing, quote, specialty crops in Orange County in the Central Valley. Specialty crops are fruits and vegetables. And many of those decisions are influenced by our societal perceptions about race, about class, about immigration, about who deserves what. So if we really want to address these social determinants of health, we thought, we need a new approach. Because if it's the folks over at Caltrans or the planning department or the economic development agency that are making the decisions that are driving health, and I'm the person that's sitting in the state health department or the local health department, theoretically with the responsibility for improving community health, I better start talking to those people. Well, unfortunately, currently, a lot of government decision-making is very siloed. Agencies tend to focus on a single goal or a single mandate because it's what the legislature told them that they're supposed to do. It's what they get paid to do. And a lot of decisions are sort of made very top-down. And a lot of decisions are very short-term in orientation. We have both businesses and politicians that are looking toward what their quarterly output is or the next election. And this combination of factors means it's very hard for us to address what we call the wicked problems, the problems that really have multiple factors causing them, that are complex, where there's a lot of things that are interrelated. Your chancellor and I went to medical school together. And one of the things that I learned in medical school is that the ankle bone's connected to the leg bone, and the leg bone's connected to the knee bone. And somehow in public health, over time, we have to get back to this much more comprehensive understanding that, in fact, everything's connected. So the health in all policies concept really rests on this idea that we all have a role to play in creating healthy communities. and that the environments in which people live, work, study, and play, and in Berkeley we always added and have sex, impact health. That the decisions made by non-health agencies play a major role in shaping environments, and that if we don't think about the health consequences of decisions that are made across sectors, we won't be able to really improve community health. Health in all policies is a collaborative approach to improving the well-being of all people by incorporating health considerations into decision-making across sectors and policy areas. So at its core, it's intended to address the causes of the causes, the whys that we started with at the beginning, so that we can influence health. And I believe that influencing health through these kinds of policy decisions is the only way, not just that we can improve health for all, but that specifically we can address these really profound and I think unacceptable health inequities in our communities. So Amy already alluded to the fact that this is not a new concept. It's really where public health started. Clean drinking water and sanitation and improved housing are what really led to the reduction in infectious diseases, boosted, of course, by medical innovations like vaccinations. But if you look at a curve, I'm sorry, I took it out for time, of the decline in infectious diseases in the US, it really predated vaccinations by quite a lot and took off steeply with the introduction of clean drinking water and sanitation. Lots of international meetings have sort of declared this idea that we have to have cross-sectoral collaboration for health. Our, crash testing in automobiles is one form of health in all policies. Our anti-smoking campaign, where in California over a quarter century of tobacco control, we've averted about 1 million deaths and $1 billion, $89 billion in healthcare costs. That's a lot of lives saved, but it didn't happen by just telling people not to smoke in the doctor's office. It happened by changing the economic environment, by increasing the price of tobacco, by changing the social environment, by doing a robust social media campaign about tobacco and the role of the tobacco industry, and by changing people's environments so that it became harder to smoke in public places and harder to be exposed to secondhand smoke in public places. It's not new, this concept in Orange County. You have all sorts of people doing work across sectors and in collaboration with each other to promote healthier communities. At the state, Governor Schwarzenegger issued an executive order that established a formal infrastructure for trying to create cross-sectoral collaboration for health by establishing a health and all policies task force under the auspices of the Strategic Growth Council, which is a cabinet-level body that has five agencies in the Governor's Office of Policy and Research, and brought together 18 state agencies, very diverse agencies, education, Caltrans, labor, social services, parks, CAL FIRE, food and agriculture, and basically said, you guys go out and figure out how you can simultaneously address some broad goals of the Strategic Growth Council, which primarily relate to climate change and sustainability, and promote healthy communities. So the first thing we had to do was sort of think about, okay, what is a healthy community? And we don't have time today to ask you all to build this definition, but we went out all around the state and talked to many, many people, both within the public health community and representing a very broad array of community groups. I see a few people that I know were at our Los Angeles meeting when we did this. And we came up with this definition, and there's a little brochure in your packets that says Health and All Policies in the front. This is in there for your later reference. And then the task force said, okay, what do we want relative to these different aspects of a healthy community, and what can we, given our mandate in the Strategic Growth Council, strive toward? How are we going to define for people what it is we're aiming for? And we developed a set of aspirational goals, things like all California residents will live in safe, healthy, and affordable housing. You all have a big affordable housing problem in Orange County, in case you didn't know it. All people will have access to places to be active, including parks, green space, and healthy tree canopy. You all have some neighborhoods in Orange County where there's no tree canopy and no parks. All people are able to live and be active in their communities without fear of violence or crime. California's decision makers will be informed about the health consequences of various policy options during the policy development process. So we picked those as the goals of our task force. You could pick many other goals related to the list of things that's in our Healthy Communities framework. You could pick as an aspirational goal that all children will receive high-quality child care and educational opportunities, or that all residents will have preparation and opportunities to engage in meaningful work with living wages, or that all residents will live in communities free of racism and discrimination, or that all residents will have opportunities for meaningful engagement and input into civic affairs and policy decisions that affect their lives. The next thing that we did was really try and think about, well, how would we track whether or not we're moving toward healthy communities and moving toward these aspirational goals, because we all know that what we measure is what we pay attention to. And so the Strategic Growth Council gave the State Department of Public Health a relatively small grant to basically come up with a standardized set of measures that would address the components of a healthy community and help develop methods and make data available to use these common indicators. And there is an effort now that includes Orange County that I'll come back to pilot the work, this work in a group of Southern California counties. Neil Maislish is leading this effort at the State Health Department. There's a website, I'm sorry I didn't put it on here, but if you Google Healthy Community Indicators California, you'll get the website and be able to see what these indicators are. As we thought about how to actually move forward past having aspirational goals and thinking a little bit about measurement, we also thought about what are some of the key themes that we think we need to incorporate as these 18 agencies came together to talk about how to create healthy communities. And we thought there was 4 things that we really needed to keep in the back of our minds in all of our work. One was we have to collaborate. Having just said that the whole goal of this task force was to create cross-sectoral collaboration, I'll come back to this again. We still had to keep remembering every time we met, we're here because we're collaborating. It's really easy for people from different agencies to get in a room and sit next to people from other places and say, I'm here because I do X. So we really had to keep remembering that we're all there to stretch our thinking about what our roles are in health. We had to keep reminding everybody that this isn't about health for some, this is about health for all. And that equity needed to be considered in everything that we were doing. We needed to remind ourselves that we can't sit in a room, whether it's at the state government level or at the city government level or at the regional government level, and just make decisions in a vacuum. That we have to understand what's happening to people on the ground to actually make sense of the policies that we're putting in place that impact those people. And once again, that we need good data to drive good decision making. So we went through a very long process, ended up making a report to the Strategic Growth Council. I'm just going to whiz through a few of the things. We organized the report into 6 topic areas. It's all on the website. Healthy foods. And our goal was to think about what can state agencies do in each of these areas to move us toward our aspirational goals and to support local governments where the work happens. Nothing actually happens at the state level. All the work happens down here on the ground and the local work that you all do. What can we do to remove barriers, provide incentives, provide technical assistance so that people that are working in communities can actually make things better and promote community health. We established a Farm to Fork office that's a tripartite effort of the Department of Education, the Department of Food and Agriculture, and the Department of Public Health to really look closely at how we could facilitate, promote, help, and incentivize, for example, schools to bring fresh produce into the school site. We've got a food procurement work group that includes the Department of General Services, the Department of Corrections, which purchases more food than any other agency at the state level, looking at how they can really incorporate healthy food guidelines into their procurement policies. Active transportation. How can we really help implement more walking, more bicycling, and more public transit? Looking at programs like the Sustainable Community Strategies program under SB 375. What can we do to support local governments in implementing complete streets so that our streets are usable by people that want to walk, by people that want to bicycle, by people in wheelchairs, by people that are skateboarding, not just by cars? How do we address healthy and affordable housing as we move toward some of the stated goals in SB 375, like promoting infill and density? How do we support urban greening in communities and access to green spaces? And how do we start incorporating a health and health equity perspective into state guidance, state surveys, state technical assistance documents? So, for example, the Office of Planning and Research is about to come up with new guidelines for general plans. Every municipality, every local jurisdiction has a general plan that's sort of the guiding vision for that municipality. And the new general plan guidelines will have a very robust health component. We put health criteria and incentives for coordinating with local health departments into some of the grants that are coming out from the state. So there's lots of different ways to incorporate a health lens into decision making. And some of those are very, very structured approaches, like a formal health impact assessment, and others are much less formal. It's having a call between Amy and Melanie about what is the Santa Ana housing element going to look like, and are there going to be things in the housing element that really ensure that we move toward affordable and healthy housing in Santa Ana. It's having a person in the Public Works Department think about what can I do to make this neighborhood just a little bit more friendly for people that want to bike and walk. So it's a range of different things. It's not a thing, but the core concept is people think about health consequences when they're making decisions, regardless of what their department is. There's a million different ways that government agencies make decisions. We make regulations, we procure stuff, we put out guidance and best practices, we have convenings like this, we do program evaluation and research. We're an employer. We create subsidies or financial incentives, permits, licenses, and of course direct services. Every one of these functions has opportunities embedded in it for applying a health lens and thinking about how our decisions impact health. So I quickly want to talk about what we've learned about health in all policies and what we think are some of the key considerations. And we think there's 5 key things that we need to keep in mind. The goals are health, equity, and sustainability. And I'll come back to that. I've talked a lot about health and equity. I'll come back to sustainability. Collaboration. Can't happen without collaboration. Co-benefits. There's lots of opportunities to identify policies that benefit multiple partners, and I'll come back to that as well. Community engagement. We have to know what the issues are confronting the people in our communities. We have to learn from them about their ideas for addressing those problems, and we need to think about how to really incorporate their thinking and their understanding as we are developing our proposed government solutions and interventions. And finally, we can't do this as just a one-off, I think on this particular infill development, it'd be a good idea for us to actually work together across planning, health, and public works. This has to be something that's embedded in the way we do our business, so that we develop over time the relationships that are required to deal with the issues that come up. And I'll talk about that a little bit too. So I mentioned how siloed we often are. It's really hard to get out of your own mental box and think about what's important to somebody else. It has been an incredible learning experience for me to sit down with people from all these different agencies. And I should have mentioned that subsequent to doing this work at the state, I've been doing this work with communities all around California. So I've been continuing to learn about how other agencies see the world. And they speak different languages. They have different mandates. They've got different challenges. They've got different stakeholder groups at the table. We can't work together without understanding what some of those differences are and starting to understand where the commonalities are so that we can bridge those gaps and actually learn to talk to each other, to listen to each other, and to work together toward these common aspirational goals. No one at our tables, whether it's at the state or at the LA County Healthy Design Work Group, or in the group that's looking at developing a health element for the city of Los Angeles, or the folks working on this in Crescent City or in Monterey or in San Diego, no one looks at those aspirational goals and says, oh no, I don't really want everybody to have access to healthy food. No one says that. So we do have a lot of opportunities to identify co-benefits. And co-benefits are basically when a single strategy, a single solution addresses multiple problems. And there's efficiencies in identifying strategies with co-benefits as well. So here's an example of a strategy with co-benefits. All of California, all California regions have greenhouse gas emissions standards that they're supposed to be striving to address to reduce greenhouse gas emissions under SB 375. And one way to do that is by getting people out of their cars. So another way to do that is by having cleaner cars. And there's a lot that's been written about the co-benefits of cleaner cars and low-carbon fuels through the reduction of air pollution, which is very important health co-benefit of those two transportation strategies for reducing greenhouse gas emissions. It turns out that if we can get people out of their cars, we would see unbelievable health impacts that far surpass the health impacts of reducing air pollution. If we could get people to shift from driving in their cars to walking and biking, including walking and biking to a transit station for about 22 minutes a day, which it's not really that much. It's 11 minutes in each direction to and from work. It would mean going from just a 2% of people using active transportation to commute to 15%. Again, it's not that much. It's feasible. We'd get a 14% reduction in heart disease, stroke, and diabetes. Heart disease and stroke are two of the three leading causes of death in California. A 6 or 7% reduction in depression and dementia. A 5% reduction in breast and colon cancer. And about a 14 or 15% reduction in greenhouse gas emissions, which I neglected to put on this slide. Those are huge health increases. They're concomitant with what we've achieved with tobacco control. We'd also see, unless we really paid attention to our bicycle and pedestrian infrastructure and stuff like traffic calming, an increase in bicycle and pedestrian injuries. So again, we need to think these things through so that we're really being thoughtful about how we implement these strategies to optimize the health outcomes. Sometimes that's challenging. Sometimes there's tensions among these different policies, and I'll just give you an example of one. Transit-oriented development is a great way to increase active transportation, because, and so is creating really complete neighborhoods where people have access to amenities within walking or bicycling distance. But in California, and especially in Southern California, a lot of the designated TOD, transit-oriented development sites, are next to freeways, because that's where we've put our transit. So one of the health risks that we have a pretty good understanding of is that if you live next to a freeway, it's not so good for you. We see increases in asthma, we see increases in adverse reproductive outcomes, and how do we deal with that? So this has been a very challenging issue to discuss, because different agencies have different mandates, and they all want to do the right thing for health, but sometimes we have to really think through how to do that right. So we've learned a lot about siting, about ventilation, about noise control, ways that we can, to some extent, mitigate the risk of putting housing near freeways. But we really need to think about, can we find places to put people that are, affordable, close to transit and amenities, but not right on the freeway. This concept of health in all policies is sort of spreading quickly. There's lots of countries that are adopting a health in all policies approach formally. Thailand actually has something about it in its constitution. At the national level, there's the National Prevention Council, the State Health in All Policies Task Force I've talked a lot about, and as I've mentioned, there's many cities and counties around the country and around the state that are implementing structures and mechanisms to create tables where many agencies can come together and talk about how we can create healthier communities. One group I want everybody to be aware of is the Public Health Alliance of Southern California, which brings together 9 health departments in Southern California, including Orange County's health department, with a focus on chronic disease prevention and health equity, but really to identify, I have a typo here, but it's kind of funny, to identify upstream policies, systems, and environmental change that impact health. And the Alliance can see what the vision is. All Southern California communities are healthy, vibrant, and sustainable places to live, work, and play. Healthy transportation. How can health departments work together to make sure that as regional agencies like SCAG and SANDAG are developing their sustainable community strategies for SB 375, that they really focus on health issues, that they pay attention to complete streets, to developing infrastructure for active transportation that's safe, and that they look at these issues like air pollution near freeways. Healthy food systems and procurement policies, and I think there's a sort of a new effort to really bring the environmental health programs into these efforts and do some regional mapping of how food systems work regionally, and then data. So this is the group that's piloting with the state health department the Healthy Communities indicators to really try and map what Southern California looks like with regard to these social determinants of health that impact health so strongly. So in my remaining few minutes, I want to talk about sustainability. Sustainability is the ability to meet the needs of the present without compromising the needs of the future. I suspect that everyone in this room cares about what happens to your children, your grandchildren, your nieces, your nephews. You don't want the decisions you make today to mean that the kids in your life that you love can't live as healthy and comfortable lives as you enjoy. And what that means is that environmental sustainability really has to be a very key piece of what we talk about when we talk about health, because all forms of environmental degradation and ecosystem collapse will have very profound impacts on health and on health equity. And the reason for that is clear. We have constructed a very impressive built environment, but in the end, humans are dependent on food, water, clean air, shelter, and relative climatic consistency and constancy. We've had a stable climate for the 10,000 years in which human civilization has developed. So this is the Barhigh framework I showed you before, very simplified. You can see on the far right health impacts and inequities, and on the far left you can see institutions and social inequities that sort of make decisions. Those decisions impact not only our living conditions, that's what I've been talking about, that drives many of our health behaviors, but those decisions also create other environmental impacts and climate change. So, in my perspective, climate change is the biggest global health threat of the 21st century. It's not just my perspective. The president of the World Bank, the head of the World Health Organization, the head of the United Nations, many governments around the world have recognized that climate change is going to affect our health directly and indirectly. And I'm not going to go through this slide, but extreme heat, extreme weather, increases in air pollution, ozone associated with heat, increases in pollen production and allergies, changes in the distribution of vector-borne disease, increases in water and foodborne disease associated with multiple factors, but particularly with rising temperatures. But most importantly, climate change will impact really the life systems on which we depend. Our food, our water, our air, our shelter, for those of you that live near the coast, our security, because there's a lot of recognition now about the way climate change really drives conflict and how that impacts where our defense dollars go and also what migration looks like. Climate change will also disproportionately impact the very same people who are disproportionately impacted by our current living conditions. So people like farm workers that work outside in the heat, people that don't have transportation to evacuate when there's a Hurricane Katrina or a Superstorm Sandy, people that don't have enough income to turn up the air conditioning, people that can't respond well to rising food prices because they're already living on the edge with hunger and food insecurity, the elderly, people with chronic conditions who are much more susceptible to the impacts both of increasing ozone levels and increasing heat. What can Orange County expect in terms of climate change? Rising sea levels. This is a map from CalAdapt, which is the state's interactive mapping that lets you look at your own community. Expecting about a 27% increase in the portions of Orange County that are subject to flooding due to storm surge and high tides as sea level rises. And there's some other maps that sort of show what kinds of infrastructure are at risk, including public health infrastructure, like sewage treatment plants or drinking water facilities or healthcare facilities. Water. I'm sure everyone is aware that we're in the middle of a very severe drought. Whether that's related to climate change or not, I don't think there's consensus among the scientists on that, because there's a long history of these kinds of mega droughts in Southern California, and we don't even know if we're in a mega drought or just in the normal up and down that we see. But we've developed Southern California in a period of time when there's been more rainfall in California than there has been for most of the last 10,000 years. So we can think about what that means. Orange County has been really at the forefront of developing water sources to address the need for having water available during a drought. But the chart on the upper right shows in the purple, I know it's a little bit hard to see, the proportion of water that Orange County, Southern Orange County, thinks it's going to get from the State Water Project. Well, guess what? No more. So, you know, these things are related in many different ways. The Groundwater Replenishment Project, otherwise known as Toilet to Tap, that Orange County does very successfully, also uses a lot less energy than doing desalinization. So I don't have time to talk about all of this. What about temperature? The forecasts are that if we achieve a low greenhouse gas emissions scenario, the Irvine area, which is where we're sitting right now, and I know it's hard to talk about this in a way when people are saying, what are you talking about? It's freezing outside. It's forecast that if we keep on our current trajectory, the Irvine area will see an increase of about 3.6 degrees Fahrenheit by about 2080. It's not really that long ago. If we keep on our current trajectory, not really making a full-on aggressive effort to reduce greenhouse gas emissions, 6 degrees, more than 6 degrees increase, with many, many more days, particularly in the inland areas, of extreme heat conditions. We know that urban areas that have low levels of tree canopy and a lot of pavement are going to be the ones that suffer the most. They can have as much as a 8 to 12 degree difference of increased heat compared to areas that have more shade and more coverage. And we know that heat is really a killer. Heat has killed more people than any other natural disasters combined in the US over the last several decades. Heat killed about 650 people in California in our heat wave of summer 2006. In 2003, between 70 and 80,000 people died in Europe during an extreme heat event. There's lots of things that we can be doing to decrease our risk of urban heat islands. And some of these have great co-benefits. So if we shade our buildings and use cool roofs, we can significantly reduce the energy consumption in our buildings, which contribute a large chunk of our total greenhouse gas emissions. If we green our neighborhoods, you know, we can not only get shade so that people aren't at such high risk of heat illness, but we can also get community gardens that provide increased access to healthy foods. If we put in cool and permeable pavements wherever we can, we also reduce the risk of flooding from stormwaters for when we have higher levels of precipitation, and we increase the replenishment of our groundwater aquifers. So these are all kinds of strategies where we see multiple benefits that include both reducing greenhouse gas emissions and increasing our community climate resilience. What will it take to move in this direction, to really implement health in all policies and start working all together as a community and across local, regional, and state government to create healthier communities and reduce health inequity? It's going to take resources and commitment and structure. It takes time to collaborate, and people have to have time in their schedules for doing that collaboration, starting with learning what other people are thinking about and where the commonalities are. It's going to take real community and stakeholder engagement. It's really going to take a clear commitment on the part of our society and our government that we want to prioritize health, equity, and sustainability, that these are values that we hold, that we want to affirm through all of our actions. And that's going to require leadership and political will and pressure from the community to make that happen. And I think that's only going to happen if we have really a very robust democracy. And I think a lot, I've been watching on the television for Black History Month, some of the documentaries about the civil rights movement. A lot changed because people stood up and said, we're not going to take this anymore. And I think all of us have the responsibility now to say we want health, equity, and sustainability, and we want all of our institutions to be working with people and communities to attain that. So thank you very much.
So let me introduce our speaker for this afternoon, Fernando Quintero, who is a strategic communication specialist with the Berkeley Media Studies Group. He provides, in his capacity as a communication specialist with BMSG, he provides media advocacy training and strategic consultation. Prior to joining BMSG, he worked as a print journalist for several newspapers, including the Orlando Sentinel, the Rocky Mountain News, San Jose Mercury News, and Albuquerque Tribune. He's a former managing editor of Latino.com, an online content portal. He's covered a variety of beats, including health, immigration, and demographics, served as a communication strategist for the University of California, Berkeley, and the University of California Office of the President, as well as multiple nonprofit organizations and private enterprises. Former director of Newswatch Project, a media watchdog organization based at San Francisco State University that promoted fair and accurate media coverage of the LGBT community and communities of color. Fernando received his BA in journalism and public relations from Cal State University, Fresno, and is a proud alumnus of the Institute for Journalism Education at UC Berkeley. Please join me in welcoming Fernando Quintero.
Thank you, Victor. I'm going to talk to you today about message strategy and how we can have conversations with our peers, with potential stakeholders, with potential allies, friends, neighbors, public officials, as well as the media, if we're in such a position to do so, about public health and how we can talk about health and the need for health policies and other changes that we'd like to see in our communities in a way that really promotes the environment or the social determinants of health that I'm sure you've been hearing and had conversations about throughout the day. A little bit about Berkeley Media Studies Group. We provide research on news coverage of public health issues to sort of see what the conversation is and sort of how public health issues are being talked about and presented and covered in the news media, because obviously that impacts how we in turn talk about public health issues and think about them as well. And we'll talk a little bit more about how news media really influences our thoughts on public health. We also do training and strategic consultation for public health departments, community groups, other organizations that are seeking to improve the health of their communities. And we also work with journalists to help them write better stories that not only focus on health problems, but also highlight solutions, which is really ultimately what we all would like to see in our communities. So today, talk about a few things: understanding the news media's role in shaping and reinforcing public attitudes, public thoughts, perceptions of community health. We're going to talk about framing recognize how frames can support or sometimes challenge our health policy goals. And then we're going to do a little bit of hands-on work and learn how to think about developing message that cue the environment and highlight solutions. And I'll talk a little bit more about that. First, let's talk about the news media and why it's so important and why we at BMSG spend so much time analyzing the news media and looking at how the news media frames public health issues. So the first function of the news and why it's so important for us to start looking at news coverage of health issues, particularly issues that you might be working on, whether it's safe routes to school, reducing tobacco use in multi-unit housing, improving school lunches, whatever health issue that you're really focusing on, it's very important for you to start looking at how your issue is being covered and framed in the news media. It's so easy for us to start turning away from news coverage. There's a lot of bad news out there. There's a lot of fluff news out there. And it's easy for us to sort of detach from the news media and not really be savvy consumers of the news media. And as public health professionals, as advocates, it's really important for us to start looking at how news is really portraying these public health issues that we care about. So the first major key function of the news is it sets the agenda. So what it is that we're thinking about, the water cooler talk, the talk with our neighbors, friends, family, is really set by the news media. So that agenda setting is very important for us to keep in mind. It also shapes the debate. So not only what we're talking about, but how we're thinking about issues is impacted, influenced by the news media. So it's very important to see how public health issues are being talked about and covered, what's being left out of that conversation, of that coverage, what's in the coverage, what images do we see, what images don't we see, who's being quoted, who's not being quoted. All of those questions are really important for us to ask ourselves when we're looking at news media coverage of health issues. And last but not least, the news reaches opinion leaders and it reaches politicians, decision makers. They obviously can't survey every single one of their constituents. They turn to the news media to see what should be on their agenda. So those three key functions are very important for us to keep in mind when we're thinking about how news is covered. So here's one example of a recent story from your local newspaper that I just chose to see how the news coverage covers the advent of e-cigarettes, which is sort of the new frontier in tobacco control. And it's a very sort of, factual story. I only included a visual and a couple of paragraphs of the story, but this is just to give you an idea that what we see in the news coverage really impacts how we're talking about e-cigarettes. Is anyone in here working on any legislation or any policy goals around e-cigarettes? I'd be curious to see what you think news coverage of e-cigarettes, how they're being portrayed, what sorts of discussions are being had about e-cigarettes, and really what you would like to see improved in coverage of the e-cigarettes issue.
Well, I think it's being sold as safer cigarettes. We think they should be outlawed.
Yeah. Okay. And the message that you see from the e-cigarette companies is really what we're battling against in terms of framing and messaging. What you're seeing is take back your freedom, I think is one of the slogans for blue cigarettes. And I just saw a new ad for an e-cigarette called Fin, F-I-N, which ironically enough means the end in Spanish. their tagline is rewrite the rules. So these messages about taking back your freedom, about really resisting government intervention, nanny state sort of proposals, all of that is very alive and well in the messages that we see from both in the news media and in public discourse. So it's very important to understand those frames so that we can start thinking about reframing. I want to tell you really quickly what we do at Berkeley Media Studies Group and what we call media advocacy, because my comments will really be sort of in the context of how we approach messaging and what we really try to do and try to help communities do with their messaging. So media advocacy is the strategic use of the mass media to support community organizing around a public policy goal. So this differs from what most people are used to, especially in the public health world, around messaging and around messages to target audiences. So what we're mostly engaged in the public health arena is what we call social marketing. So all of those billboards and bus placards that we see, eat your 5 fruits and vegetables a day, wear condoms to prevent unwanted pregnancy and HIV. If you drive down the Central Valley, you'll see the billboards that tell farm workers in Spanish, seek shade when you hit triple-digit temperatures. All of these messages are designed to change individual behaviors to improve community health. What media advocacy does is promote messages, or rather relay messages that promote policy change that helps improve community health on a community level. So that's why we focus a lot of our energy and time on making that distinction and how those messages differ when we're talking about trying to change individual behavior versus trying to make changes on a community level. So those placards and billboards that I was just talking about, social marketing, which we're all familiar with, it's really, like I said, that individual focus. It's about educating us, warning us, informing us, so that we can change our behavior and be more, be healthier. It's about making personal change. It's about a message that is self-contained to get you to change your behavior. It's about bridging the information gap. If we can only give our community, the information they need to be healthier, to eat better, to exercise, that's the message that sort of social marketing focuses on. Whereas media advocacy is really about focusing on an issue. It's about pressuring and mobilizing not only decision makers, but also community members who obviously can pressure community, or rather decision makers. It's about policy change versus behavioral change. It's about giving voice often to the voiceless. And it's about bridging the power gap versus the information gap. So that's the major distinctions between media advocacy and social marketing. And when we're talking about engaging in media advocacy, it's really about being strategic in your communications. So these considerations are what we need to keep in mind when we are involved in media advocacy versus social marketing. In media advocacy, the first thing you want to do is you want to identify the problem or issue. There are so many issues out there, so many health issues. They're interconnected, but you can't be strategic and comprehensive at the same time when it comes to media advocacy. So it's really about picking your battles, identifying that problem or issue, and then articulating it what is the solution to that problem? Oftentimes we talk about problems and we say, if only the community came together. Well, then what? So it's about asking the community to come together for a particular reason, to advance a public policy, to call for accountability of an existing policy or law, but it's really about highlighting that solution. It's about naming who has the power to make the change. Decision makers, politicians are supposed to be accountable to the communities they serve. So in reverse, we need to call out who has the power to make changes in our community that can improve the health of our communities, who must be mobilized to apply the necessary pressure. So that again is, who in your community is going to be the best voices to speak to other community members and to the decision makers. And then last, what is it that your targets need to hear, whether it's the community that you're trying to mobilize or whether it's the decision maker that you're trying to reach about improving community health. So now I'm going to talk about framing, which is really sort of the topic of the day. How do we reframe the conversation that is being had right now around public health? Well, first of all, we need to understand what the current framing or thought process, whatever you want to call it, spin. There's all kinds of ways to think about framing, but it's really about what we sort of bring to the table and how our history, our political background, our religious upbringing, all the things that impact us and form, the individuals that we are, really impacts and colors how we view the world. So this is an exercise to sort of show you how framing works. So can someone tell me what it says behind the blue bar? Prevention works, right? Well, we might have some skeptics because this is what it actually says. I'll do that again. So this is to sort of illustrate the idea of framing. We all fill in the blanks. And so this becomes a challenge for us as public health advocates and professionals, because the dominant frame in our culture, and this relates to both the public at large and the news media, is this idea of individual responsibility. It's the narrative of our country, rugged individualism, pull yourself up by your bootstraps. It's what made this country great. It's what we revere about this country and our culture as Americans. It's what the news media loves to tell in terms of storytelling. The person who overcame all obstacles, all adversities, all odds to succeed, to lose weight, to beat breast cancer, to whatever it is, to become a successful entrepreneur and rise above poverty. These stories are really compelling narratives that are told over and over and over again. But the problem that we encounter with this dominant frame or narrative is that it also conversely says to us, if you are obese, if you are poor, if you are suffering from emphysema, it's your fault. And the environment that you live in, the social determinants of health that we talk about, have nothing to do with that. So we need to put the environment first and foremost because it's invisible. That default frame makes the environment invisible because we're also conditioned to look at the personal responsibility frame. So how do we start sort of reframing that conversation? And it's a challenge. I'll tell you, it is a challenge, because frames, like the structures of a house, hold up our whole belief system and our value system. So we really have to work against that very entrenched default frame that exists in our country and that is perpetuated by news media stories. And the reason it's so important to reframe that conversation is because we do have that default frame that is so pervasive, so dominant. This scale represents research that we did around television news coverage of public health issues and how a institutional or environmental frame was presented. In other words, what were the factors outside of one's control that undermine or impact one's health versus, the personal responsibility frame. What we found was an 80%, 20% difference. 80% being the personal responsibility frame. And as a former reporter, I can tell you that it's not a conspiracy by the media to present this type of framing. It's simply that reporters and editors, like anyone else, falls into the default frame. And so our way of thinking, our way of writing a story and thinking about a health issue is to personalize it, put that poster child, lead into your story. News writing is very formulaic. And so we see those stories where health issues are really personalized and humanized. But what those stories do is fail to stretch that frame out and show the landscape. All they're showing are portraits. And so we need to really reframe that conversation. And this is another example of what we're up against. It's a sensational headline, but it gets to the idea of personal responsibility. And this is a story about healthcare. People who were obese were being blamed for healthcare costs. And yes, as we all know, obesity is taking its financial as well as health toll on our communities. So how do we reframe? First, what I've been talking about, cue the environment first. When we're talking about sugary drinks, we can talk about how parents need to be better parents and quit buying soda. We can talk about high school kids being better kids and taking more responsibility for their own health. They're little adults. They should start making healthier choices at that age. Or we can talk about the environment and say, of course parents need to take responsibility for their kids' health. But parents need help because we live in an environment that is saturated with soda products. I know that when I lived in the Mission District in San Francisco, my corner bodega sold sodas cheaper than water. So that was the kind of environment that we lived in. In the condo that I lived in, there was a billboard right on top of our condo advertising Coca-Cola. When you go to a corner store, sometimes you can't even get diet products. Not that diet soda is any better than sugary drinks, and the science is really proving that they're both just as dangerous. But the science clearly is pointing now to sugary drinks as a major contributor to extra calories that are making kids and adults sick. So we need to paint a clear picture of how the environment undermines our attempts to be healthy. We need to assign primary responsibility. Is it a school board that needs to remove vending machines from the school and put hydration stations in? Is it the city council that needs to make a change in multi-unit housing? Whatever it is, we, again, as I mentioned earlier, we need to assign responsibility, make people accountable. Present a solution. We talk too many times about the problem, not enough about solutions. Advocate for policy, That most of the time is going to be your solution. And then we can develop what we call story elements that support our frame. And I'll talk a little bit more about story elements. But here is an example of an individual versus an environmental frame and how we can start thinking about messages and how we can start reframing the conversation. So here is a sample of an individual frame. Smoke-free multi-unit housing is a terrible idea. People should be able to smoke in the privacy of their own homes. If you don't want your family exposed to secondhand smoke, then don't smoke inside your home. A lot of people would think, you know, that's a very reasonable statement. But again, it's a default frame that really points to individual personal responsibility. So reframing that statement would start with a good, what we call a media bite or sound bite. When you smoke in your home, you smoke in mine. Smoke from one unit or common area can travel through doorways, cracks in walls, plumbing, and ventilation. While residents can prohibit smoking in their own units, adopting a smoke-free policy for multi-unit housing will ensure all residents are protected from secondhand smoke. All residents of Orange County deserve to breathe clean air, no matter where we live. So here is a message that clearly puts the environment first, paints a picture of what it is that we're dealing with. It includes a solution, and it includes a value statement, which we're going to talk about a little bit more. Values are an important part of your message, and infusing your message with a value is what is really going to resonate with your target here versus here. So we want to hit them in both places. The facts, the data, the evidence is going to hit us on, rational, sort of cerebral basis. But it's those value statements about why it matters. Why it matters to protect children. Why it matters that children's potential is realized. That's really what we're talking about on a values basis. And that's what's going to hit our targets here. So we'll talk a little bit more about that. Components of a message, it's not rocket science, folks. It's very simple. You've got your statement of concern, what's wrong? So whether you're giving your elevator speech to a potential ally or a community member, whether you're talking to a neighbor across the fence, or you're giving testimony at a city council hearing, these three elements of a strategic message should be included. What's wrong? What should be done? And why does it matter? And why does it matter can be answered in two ways. What'll happen if nothing's done? And what value do we want to evoke? And so we'll talk a little bit more about values. So here's a word cloud, if you will, of values. Can anyone add to that, or does anyone have a favorite value that's connected to the work that they're doing? Choice. Okay. Choice is an important, freedom of choice. Oh, it's tricky. Because the word choice conjures up the idea of personal responsibility. So we often say, make the healthy choice the easy choice, which is a great slogan for public health departments. But do you really have the ability to make a healthy choice if you live in a food desert? Or if you live in an urban area where there's no access to healthy foods or physical activity at all. So, providing choices. Other values.
Duty.
Duty. Say more about that. Duty to protect?
Yes, especially if you are hired to represent a bunch of people, elected or otherwise. It's your duty to act in their best interest.
Absolutely. A lot of public health professionals right now feel like their back is up against the wall because they're being told, you know what, you're telling us what to eat and drink. You're butting your nose into my business. You know, we hear, as I said it before, we hear the word nanny state a lot. And so public health departments are under attack. And this value of duty is what I would say is the response. I am proud to represent the public health department and protect the health of the residents of my community. This is a role that I take seriously, and I'm proud of that role. That's your response. And we have to really think about, you know, how we really connect on that values sort of basis with the value of duty to protect. Absolutely. Any other values you can think of?
Empowerment or empower?
Empowerment, empowering communities, absolutely. That's a value that can resonate. Any others? Justice, social justice. A lot of us do this work because of the injustices that we've seen in this world, and we want to address them. And social justice is a very strong value if it connects to your target. If your target could care less about social justice, then you're going to want to come up with another value, maybe fiscal responsibility. I saw another hand up there.
Dignity.
Dignity, that's a good one. That's a real good one, especially around debates of palliative care, you know. Everyone should have the right to live and die with dignity, absolutely. And let's place the emphasis on live for today. Okay, so this is just to give you an idea of how these values that may sound shrill to some people, but if they're authentic, if they're values that motivate us to get up every morning and do the work that we do, and if we can name those values are the ones you're going to want to use because they're going to come from a place of authenticity and they're going to connect to your targets. So include a value statement in your message. Here's another example of a message with those components. What's wrong? The residents of multi-unit housing in Cityville are exposed to secondhand tobacco use, which can cause respiratory problems, heart disease, and lung cancer. Why does it matter? Secondhand smoke is a deadly health hazard to children and families. All residents of Cityville deserve to breathe clean air inside their own homes. What should be done? The Cityville City Council should pass a regulation outlawing tobacco use in multi-unit housing by March 2014. So this is just to underscore the idea of problem, solution, and why it matters. Very simple, not very long message. It can be quite effective. Another way of being strategic in your messaging is to be prepared for the tough questions that you're inevitably going to get about the work that you're doing. Does someone want to give me a tough question that they get about the work that they're doing? Do they look like these? Does anyone have a specific example? Why are you spending money on this initiative, this program, this proposal, when we have so many other needs? The competitive issue?
I think it's like, even listening to the conversation today about CBS going tobacco-free, it's like, okay, so what's next? Is it going to be, are you going to get rid of the drinks next? Are you going to get rid of the candy next? When are you going to stop taking away my options?
So more of an attack on our liberties, our way of life. Are you going to take away my hostess cupcakes next. And absolutely.
If this is such a big deal, what's taking you so long? Whatever. I hear that a lot.
Why now?
I know.
Why now? Absolutely. And the worst thing is to be caught without a response. So this part of your message strategy is really important, folks, is having these responses ready. And how do you come up with them? You just ask the questions that you would dread getting. Have a little brown bag luncheon. Get together with your favorite colleagues. Brainstorm some tough questions and brainstorm your answers. This is what we do in training, and we've come up with wonderful responses to some pretty tough questions. So this is an important part of your message strategy, is being prepared. Victor, did you have a question?
Yeah, so maybe I'm getting ahead of your presentation. If I am, please feel free to tell me so.
Sure.
So there, you said earlier that, you know, the message at the outset, that the messaging we get every day about certain things is constant, right, and unrelenting. And you know, if you're a group of people, everyday people, even if you're working in a coalition, the issue of financing and the ability to have access to mainstream media and to get your message out on a regular basis. I mean, what was the Super Bowl ad this year? $4 million so, you know, and I mean, I've heard responses that say, well, that is a problem, but there is the issue now of social media, that we have access. And you see examples time and time again, you know, the presidential election, you know, some other, you know, other larger social movement related campaigns where they have effectively used social media. So, but there is still that issue about the ability to regularly message your message when faced with, you know, with competing against larger forces.
Well, part of it is, you know, being strategic, getting media attention for your issue is, you know, it does take strategy, and it's another training that we offer. Let me give you the 3-minute version. You have to know what is newsworthy in order to get coverage. And there are different ways of making your issue newsworthy if you get creative. So getting attention is about knowing what your news media wants. And knowing what any news media looks for. So a seasonal holiday link, broad interest, local angle, irony, conflict controversy, all of these elements of newsworthiness, if you know those elements and can pitch your story and talk about how your story meets these different criteria of newsworthiness, you're more likely to get coverage of your issue. Valentine's Day is coming up, and a lot of health advocates have used that holiday to piggyback and get their issue in the news. So there was an environmental group that was trying to draw attention to dangerous pesticides that are being used on flowers, including red roses, which is a favorite for Valentine's Day. They pitched a Valentine's Day story about red roses and the hazards of toxic chemicals, of being exposed to those toxic chemicals. So they used Valentine's Day as an entry. There was a group, I believe, here in Orange County. Yes, in fact, I might have. There was a group in Orange County that I was just reading about. I thought I might have used it in one of my slides. that was promoting. It was a foundation that had that was supporting an organization called Mi Vida, Mi Corazón, which is my life, my heart, which is a program to reduce heart disease among women. And it was a local free clinic. I see some heads nodding, so you might be familiar with it here in this room. This foundation used Valentine's Day to say, it's Valentine's Day, we're all thinking about the hearts. So here's a program we want to draw attention to. So they use the symbolism of the heart to use that as an anchor, as an entryway. One more example I can give you are gay marriage or marriage equality advocates that have used Valentine's Day to stage protests at City Hall. It's a day of love and celebrating love and here's an entire class of Americans who are not legally recognized for their love. So there was another example of a group using Valentine's Day to piggyback on. So there are lots of strategies that you can use, but it's really about knowing what is going to draw attention from your news media. And right now I'm talking about story elements, and these are ways to support your frame. Remember, we're talking about reframing the conversation, showing the environment. So story elements are ways to support your frame. One way to support your frame is with the messengers that you have. So message is important. The messenger is just as important. Who's delivering your message? And we talk about authentic voices because these are people who can speak to an issue from a place of authenticity. They may be young people, they may be parents, they may be teachers, they may be school administrators, they may be law enforcement officials, pediatricians, school counselors, faith leaders. We can go on and on. Every community member is interconnected, and health issues in our community, as you all know, are interconnected and impact us all in many different ways. So if we can speak to the importance of addressing this public health issue from many different voices who can talk about why it's so important for this problem to have a solution, authentic voices can really go a long way. So here's an example of Wise Up, which is a high school student-led group focused on immigrant youth, a lot of DREAM Act work that was going on with this group. And they've expanded to over 10 high schools in Southern California, including Orange County. Sound bites are important. Here are a few examples. Kids need sports, not sports drinks. The only medical voice on the big soda side of the debate is Dr. Pepper. Anyone who smokes in multi-unit housing is not just smoking in their own home, they're smoking in mine. And I used that soundbite in one of the earlier messages that you saw. Soundbites are important because, even if it's a 30-second elevator speech, your listener sometimes can just hear a bunch of this going on. If it's long-winded, if it's too wonky sounding, if there's too much details, if you went too much into the details and not into the value, problem, solution statement, all of that can sort of, cloud or muddy the waters or whatever, analogy you want to use. Media bites or sound bites, which we're all familiar with, are memorable ways to remember your message. If you only have a 6-word soundbite, it might be all that somebody remembers from your conversation. But if it's pithy, if it's memorable, humorous, ironic, whatever you want to, whatever approach you want to take, they're great to have in your message. Visuals. Picture's worth 1,000 words. It's a great adage, and it's really true. This image you've all seen. It's kind of been done. There's a lot of talk now about sugary drink fatigue. And so we really need to come up with some fresh visuals. This one was very effective, though, because we still have people saying, there's really that much sugar in a can of Coke? People just don't realize that. So when we break it down in a visual way, it's very effective. Social math. We use data and numbers a lot to make our case. But oftentimes, numbers without the proper context, without some way of making meaning or sense of them, are just numbers. And, you know, I'm one who just glazes over when somebody starts reciting a bunch of statistics or numbers. So social math is a way to provide meaning and context to a number, a way to make a number meaningful. So with this first social math example, one way of saying the toll that tobacco has taken on Americans is to simply say a number. In 2013, now I'm just going to make this up, 400,262 people lost their lives due to tobacco use. You might say, wow, is that a lot? Has it gone up? Has it gone down? You know, it sounds like a lot, but maybe it's not a lot. Now let's paint a picture. 1,000 people quit smoking every day by dying. That is the equivalent to 2 fully loaded jumbo jets crashing every day with no survivors. I hate reading this quote when I have to get on a plane, you know. But that's one way of making numbers come alive. Tobacco industry spends more money promoting smoking in a week than the entire federal government spends on preventing smoking in a year. So there's a little irony there and some social math to make these numbers come alive. So, in summary, being strategic is really about thinking about your message in that landscape way and making the invisible visible and staying away from that portrait that is going to bring the default frame back to personal responsibility. So when we're talking about being strategic, your message is never first. First, you want to think about what you want. What's your goal? A lot of people say, "Oh, we need a press conference. We're going to announce this new initiative, this new health initiative or proposal. Let's get a podium, a speaker, and maybe a ribbon and some scissors, right?" And we don't think about, take a step back. Well, what is it that we want to accomplish? How are we going to get there? Who's going to be our messengers? What's going to be our strategy? So before you think about your message, take a step back and think, what is it that I really want to accomplish here and how am I going to do it? Know what you want and how to get it. You don't want to create news just for news' sake. A lot of people think, well, maybe if I just get some media attention on this problem, maybe if I have some bloggers, or maybe if I send out a tweet, I'm going to get, people really talking about this and shining a spotlight on this issue and the decision maker who is stalling this great policy that would improve community health. Sometimes that's not the way to go. Sometimes a simple meeting with a decision-making board is what you need. And the last thing that you want to do is shine a spotlight on them. So you want to be strategic there. Illustrate the landscape, connect your values to solutions. So, in a nutshell, that's media advocacy, strategic messaging, and I'd be happy to take any questions. Y'all get it?